Hello and welcome everybody to our TIF Talk. Thank you for joining us. We're very excited today. We have a very special guest from Europe. We have Dr. Rehan Haidry here with us today. Dr. Haidry, thank you so much for joining us today. We really appreciate it.
Hey, Andrea. Hello to the team. What an absolute pleasure to be on this TIF Talk. So really looking forward to it, and thanks.
You're welcome. Thank you. So before we start, I do want to remind everyone this is a live event. You'll notice I have someone sitting here with me. So I'm Andrea Millers with Endogastric Solutions. I am the Senior Director for Marketing here. And we also have Wendy Profit joining me today, who is the Market Development Manager for the East Coast here in the US, if you will. So thank you, Wendy. She will be helping with all of the questions that come in live. So at any time, if you have any questions, please feel free to type them into the chat section and we'll do our best to get questions. I will tell you, Dr. Haidry did ask me to call him Rehan by his first name. So it's gonna be very, very hard for me to do, but if you hear me call him by his first name, he requested that I ask it. Before we start, I do want to give you a little background on Dr. Rehan Haidry. He is a consultant gastroenterologist and interventional endoscopist, at University College Hospital in London and also Cleveland Clinic, London. He leads the upper GI interventional endoscopic unit. His main interests are therapeutic and innovative endoscopic. In particular, he has focused his interest in pre-malignant and malignant disorders of the upper gastrointestinal tract, with a particular interest in Barrett's neoplasia, squamous neoplasia, and esophageal cancer. He has an academic position of associate professor at UCL, where he supervises his team to generate research into the endoscopic techniques and procedures he carries out to improve and streamline the care that they give to their patients. His research is focused on existing and novel endoscopic imaging technologies for detecting early cancers, such as artificial intelligence. His other main research focus is minimally invasive techniques for treating cancers of the upper gastrointestinal tract, and continues to lead and be involved actively on several national and international clinical trials in these fields. Dr. Haidry has offered the TIF procedure since 2019, and he was the first endoscopist in Europe to perform the TIF 2.0 procedure. So again, Rehan, thank you so much for joining us this evening. We really appreciate you being here.
No, an absolute pleasure. Really looking forward to it. Thank you.
Fantastic. So we're gonna go ahead and start our program. The first thing we kind of like to ask and have you explain is, what is GERD? What are the types of symptoms that patients would be feeling or experiencing if they were?
Thanks, Andrea. So listen, gastroesophageal reflux, GERD or GORD as we call it here in England. It's a common phenomenon in Western adults. Most of us are allowed to have a little bit of transient reflux on a monthly basis, but where it becomes a problem is where it occurs on a more frequent basis. So essentially what is happening is that our stomach, which sort of sits just under our diaphragm, it's quite a hostile part of the GI tract. It's full of acid, it's full of bile, it's full of pepsin. And on the whole, the trajectory of all of that stuff should be going north to south. And what happens in acid reflux, not just acid reflux, but also non-acid reflux, is all of that stuff, the bile, the acid, the pepsin, it comes back up north into our esophagus. And that's what will give us the symptoms, Andrea, that a lot of folks will see their doctors with, the sort of textbook symptoms, heartburn, a sort of, a burning reflux type sensation in their chest. Some patients will even get acid or a sour taste in their mouth. Some people will regurgitate, not just the liquid, but food. They'll have difficulty swallowing. I see a lot of patients who come and see me with none of those symptoms, and they'll have quite quite different symptoms, like a lump in the throat or a sore throat or a chronic cough or a disturbed sleep. So it's a common problem, and it can affect all of us in so many different ways.
I thank you for that.
So many different ways.
I thank you for that. We appreciate that. You did mention the non-acid reflux. We call that over here sometimes. Patients will say LPR. Are you familiar with that term?
Yeah, for sure. It's LPR it's a universal term for what we call laryngopharyngeal reflux. And what I try and get the patients to understand is actually reflux of acid and non-acid it's a basic issue with the plumbing in our esophagus and our stomach. So the junction between our gullet or our esophagus and our stomach there's this preconception that there's a valve, but there's no such thing. All there is, Andrea, there's a ring of sort of circular muscle that sits there, and in the resting state, as you and I are now talking, that muscle is in a state of what we call high pressure. It's closed. So when we swallow consciously or subconsciously, our brain tells those muscles to relax, and it allows food and mucus and liquid to go down. What underpins the issue in all reflux, acid and non-acid, is that muscle gets weak over time. And there's lots of things that can contribute to it. So basically what happens is that liquid, acid and non-acid, will come up, will give us the sort of characteristic symptoms, but will also, not just the acid, but the vapors from that acid and non-acid can irritate the back of your throat. And a lot of those LPR symptoms that you talk about will present and can be a real impact on people's quality of life on a day-to-day basis.
Sure. Yeah, perfect. Thank you for explaining that. That's great. So, what do you normally tell patients to do, or what is to manage their GERD? Obviously before it gets to a point where medical therapy or if they need a procedure, there's the lifestyle changes and.
Yeah, I think the first thing in medicine, which we were all taught, is sit and listen to your patient. Nothing beats a good history, because we mustn't be over treating patients, and really understanding why they're there. Before you label them with reflux or put them down that sort of chain of events, it's really important to understand why they're there, what's affecting them. Chest pain, problem swallowing, can be a lot of other things that we need to decipher and make sure. And then once you're comfortable that your clinical history taking is confirmed reflux, then simple things, the low-hanging fruit here, guys, is simple lifestyle changes, from how we eat, when we eat, our portion size, small meals more often, giving ourselves a good couple of hours before we have our evening meal and lying down, reducing weight, anything that's going to push your intra-abdominal pressure up on your diaphragm. That's why pregnant women in the first and second trimester get reflux, is they're mimicking what's happening to the Western world. We're all getting obese. Cutting out smoking. We know that nicotine, we know that alcohol will reduce the pressure in that valve. We know that certain foods, for example, carbonated drinks, will decrease the pressure in that valve. And we also know that there's certain foods, like fatty foods, there's a little bit of evidence they increase not so much reflux, but the sensitivity to the reflux. So that sort of stuff can make a big impact on people's symptoms just by them tailoring their lifestyle, and that will avoid them then having to go on to medical therapy and ultimately end up in my room with a TIF procedure on the cards.
Right. Perfect. Thank you. So can you talk a little bit about what types of diagnostic testing do you do to determine if a patient in fact does have refractory GERD, or is at that point where they need to go beyond, that the lifestyle changes or the food?
Yeah, look, I think that, we have to be cognizant of the fact as clinicians in this space that we I talked about overdiagnosing patients. We mustn't underdiagnose patients, because we know that chronic acid reflux in a small proportion of patients will predispose to something called Barrett's esophagus, which is a precancerous condition. So we need to make sure that we find these patients. And Andrea, the reason I say that is because, most of my work is in the esophageal cancer space, and we've got a lot of work to do there still. This is a disease that still carries a poor prognosis. We need to intervene early. So answering your question, after a good history taking is, I think, an upper endoscopy, a gastroscopy or an endoscopy to visualize and interrogate the esophagus, the health of the esophagus, to make sure that there is what we call esophagitis. It's basically inflammation of the esophagus. Over time, the esophagus can get narrowed. It can create something called a stricture or stenosis. And then also to look for something called a hiatus hernia, which a lot of patients with reflux may have. And a hiatus hernia in English basically means that your diaphragm, which sort of separates your chest from your abdomen, a little bit of the top part of your stomach pops up and it herniates, and you get this sort of redundant piece of stomach which will just accumulate food and liquid and bile and acid, and that will just predispose to acid reflux. So that's the first test to do, is to make sure the anatomy is okay, take biopsies, and give your patient a baseline. And then, Andrea, in the patients that are still suffering, what we want to do is we want to label their reflux. We want to quantify it. And one of the things we do is we measure how much reflux is coming up. We do that either with the probe that goes through the nose and it sort of sits in your esophagus. I've had one. It wasn't too bad at all. One of my fellows did it on me. And the other way is a pH probe that sucks onto the esophagus called a Bravo, which measures for 96 hours. And Andrea, the point of this is to give the patient, put the patient in charge of their sort of destiny. And what I always say to them is, this test will tell you how good or how bad your reflux is. If the pH probe comes back and actually the percentage of time in reflux is not too bad, we can reassure them that, lifestyle changes, a few antacids will help you, but don't worry. When you get those symptoms, you're not dying of cancer. Conversely, if it comes back really high, they're the ones that we just need to focus our attention on.
Perfect. Thank you so much for that. I believe we have a couple of questions that have come through. Wendy, I'm going to pass it over to Wendy to get those questions asked to you.
So we have Lynn asking if GERD can heal on its own, or also if it doesn't, can it worsen, and what can it evolve into?
Yeah. Thanks, Wendy. So Lauren, absolutely. What GERD causes is two things. One is it gives you the troublesome symptoms that impact on your quality of life, which is obviously what you're worried about and what I'm worried about. But what I'm most worried about is what you're not aware of, is the damage it may be doing to your esophagus, that irritation, that inflammation. That's what we're concerned about, and absolutely it can heal. So if you turn your esophagus from an acid environment to an acid neutral environment through the lifestyle modifications, through antacids, through drugs that we can talk about, which reduce the amount of acid in your stomach, absolutely you'll achieve healing. The worry is, Lauren, if that doesn't happen over the long term, then that healing inflammation can predispose to some of the changes.
Right. Thank you. So could we also, I think that's a nice segue into the medical therapy that you touched on. Could you talk to us a little more in detail about what that protocol looks like, what you recommend?
Yeah, for sure, Wendy. So again, I'm a big believer of less is more. We mustn't, we have to be pharmacovigilant in this day and age. And so the cheap and cheerful options are what we call antacids. So alginates, in our country, Gaviscon, Pepto-Bismol, Peptac, that sort of stuff. And all that does is it does two things. It neutralizes the acid. So it's a quick fix for the burning symptoms or the heartburn or the indigestion. And the second thing is the alginate in it creates like a little barrier on top of that pool of bile, acid, food, and it sort of stops things from coming up. So, but that's a reactive intervention. A slightly more proactive intervention, Wendy, would be to reduce the amount of acid that your stomach is making, thereby reducing the amount of acid that's available to come up. And the two drugs that have been used are called proton pump inhibitors and H2 antagonists. Now, basically, what those two types of drugs do, that they're two sort of pathways in the stomach that produce acid, and what those drugs do is they block those receptors and stop the production of acid. So, you would have heard of drugs like omeprazole or lansoprazole or Zantac, ranitidine, famotidine, a lot of which now we buy over the counter. Over-the-counter drugs, and in a controlled manner in the short, medium term, they will control the symptoms of acid reflux, and as importantly, they will improve the health of the esophagus.
Yeah, Rehan, you're actually talking to two people who take both. PPIs, I'm on it daily. I don't know if you're on it daily anymore, but yeah, we are very aware of PPIs, unfortunately.
I made a couple of the lifestyle modifications that we don't love to talk about, but I did it, and I'm not on the PPIs any longer, but every once in a while I have a need for an H2 blocker.
Yeah.
But that's such an important point that you make, Andrea, is that this is a Western problem. It's a catalyst of the fact that a lot of people on this call today are doing exactly what you guys are doing. You're juggling a lot of different balls.
Yeah.
One of the questions a lot of my patients ask me, does stress cause acid reflux? Now, there isn't a randomized control trial to say that is the case, but hell yeah, of course it does. That's anecdotal advice that of course it does, but I haven't got a great cure for stress. Otherwise, I wouldn't be on this call. I'd be on a big yacht in the Caribbean. But all of those things,
with giraffes. But yeah. So, do we have more questions? Thank you for mentioning that. It is
well, and actually, what I'd kind of like to do as well is just talk about, when is it time for somebody who is taking medications to see somebody to just get a little more information on what's really going on the inside, because we talk about how important it is that you really want to see, for yourself what is happening to that lining of the esophagus. And then also, after you touch on that, would you mind talking about what you do for patients with non-acid reflux and what is on that?
Yes, gosh, two pretty tricky questions. So the first one, it's a dynamic conversation with your patient to make sure that you're meeting their expectations. But the things that you look for are patients who are compliant with their lifestyle modifications, compliant with the medications, still having symptoms. They're the ones that we just need to up the ante to make sure that we do one of two things. One is we can escalate the dose of their medications. We can add in a few extra medications. Or in a few patients where that's not the case, we can consider procedural intervention to try and tighten that plumbing. And that needs to be done in a really careful way, and that we don't want to be sending patients off for intervention unless they absolutely need it. But there's so many different factors that need to be taken into consideration: age, other health factors, compliance with medication. And one of the things that has been in the press, rightly or wrongly, over the past 10 years is all of these meds that we've talked about that you and I pop fairly frequently. There is some evidence that they do come with a bit of baggage, and we just have to be vigilant of the patient's expectations, because the bottom line is that these drugs are safe in the short term. There's no doubt about it. Otherwise, we wouldn't be allowed to give them. But there is a bit of noise in the press, in scientific journals that suggest that the long-term use of these drugs in moderate doses can predispose to a few conditions, and it all stems from, we need acid in our body. Our gut needs acid. So, intuitively, of course, if we're suppressing acid over a long period of time, the rest of our gut that's further south will suffer. And I see a lot of patients who've been on these drugs with SIBO, bacterial overgrowth, bloating, and then there's also it can increase the permeability of your gut. So you see some patients with magnesium deficiencies, which can be quite tricky to manage. And then there is also some evidence about the fact that because of the decreased gastric acid, you're decreasing calcium, and this can predispose very, very slightly, and the data on this is conflicting, to bone fractures and osteoporosis. So patients know about this, they will challenge you, and it's our responsibility to be able to face that up to them. But also, what's the risk of erosive esophagitis to the esophagus? So there's a risk benefit here. The second part of your question, which is non-acid reflux, gosh, that's a difficult one to test. I don't have a great test for that. And that will come through, again, history taking, through there are some studies like impedance, for example, which look at almost pressures of the proximal esophagus, and in these patients we know that pills like the PPIs and also interventions tend not to do so well. So it's all about patient selection and making sure you're not missing anything.
Right. It's a good point. And I think for me, personally, I'm concerned about taking it so long, right? I go back to my doctor, just my nurse, just regular doctor, and they just keep saying, yeah, just keep taking it. If it's working, just keep taking it. And at what point, do you say, I can't just keep taking this. I'm starting to worry about, dementia, osteoporosis, but not. I'm getting older, and I don't want to get, 20 years down the line and, not do anything about it. So I think this is one of the great things that we're doing today, and with other physicians, and every Tuesday, our TIF Talks, just to, build awareness around GERD and the options. So that kind of goes into our next segment, talking about what are the kind of options after lifestyle modifications, after, medical therapy. Then what? Can you please go into detail a little bit about what are the options to actually treat GERD instead of just, minimize symptoms? So,
Andrea, it's an interesting concept as an endoscopist in this space. Up until 5-6 years ago, we weren't really present other than to make a diagnosis, or at the very other end where there was catastrophe to deal with the outcome. Because there was this very sort of binary approach to managing tablets, and in those in whom we'd done our due diligence and they had reflux, is then an operation. And it's called a Nissen's fundoplication. It's done laparoscopically and will remain the gold standard for some patients who need it, but patients with really bad reflux, patients with big hernias. Our surgeons are so good at doing this procedure. And it's safe, but like with everything we do in medicine, it comes with side effects, bloating, dysphagia in up to 10% of patients. But absolutely, for some patients, to protect their esophagus, they need that operation. And, my conscience is clear putting them in front of the whites of the eyes of a surgeon. But what's the space that's opened up, which is, kind of why you and I are here, is that bracket of patients who haven't got the big hiatus hernias, who have got terrible reflux, who've got symptoms that are impacting their quality of life. And that's where the endoscopic options come in. And historically, there were ablation techniques for reflux, but really the evolution of the endoscopic fundoplication with the initial TIF and now the 2.0 really means for our viewers here is we're able to mimic what the surgeons do in a less invasive, the word we all use is minimally invasive way, through the gastroscope, like you would have had at baseline, to basically create that wrap, we're able to take your stomach, wrap it around your esophagus, your gullet, and also if there is a small hernia, pull it down and create a new valve. In 30 minutes, you go home that same afternoon. So the answer to your question is the therapeutic options have opened up to us, and it's all about, it's great for the patients.
Love that. Love that. I love it. Thank you. I do see a couple of more questions popping up, so I'm going to pass it over to Wendy to ask those questions.
So Maria is asking, I've suffered from GERD for many years, 12 in total. I've been on PPIs for many years as well. Now the symptoms have changed. There's no more burning sensation, but I do have increased phlegm and a lot of clearing of the throat and difficulty swallowing. I stopped my PPIs because I'm trying to control them with diet. Could I benefit from a TIF?
Hey, thanks, Wendy. Hi, Maria. So listen, first of all, listening to your symptoms, I don't think there's anything to worry about. Nothing you've told me makes me want to, endoscope you tomorrow. 12 years is a long time to have acid reflux. And, as soon as your symptoms change a little bit, that's when we just need to be a little bit more cognizant of making sure we're not under-treating you. So if you've had a bit more phlegm, a few issues swallowing, listen, I'd engage pretty soon with one of your docs and get them to put a scope down, but also encourage them to try and measure how much acid's coming up, especially now you've stopped your drugs, because that'll give you the information you need to make an informed decision as to whether you need, TIF may be an option.
Very good. Thank you so much.
Any more questions, Wendy?
Well, just in getting back to some of the discussions we just had, we do have physicians, patients report, my doctor says I can just keep taking my PPIs, but I've heard it's not good to stay on them for a long, long time. Do you have a certain time frame or a dosage or a frequency that you recommend once they've reached that point or symptoms, when it's time to really see somebody and seek a different type?
Yeah, Wendy, that's a big question. And again, the variables that inform your decision making are not finite here. There's the patient age, the symptoms, the comorbidity, but ultimately the key here is to protect the esophagus. And I go back to what I'm saying is that if your patients are on this for more than 12 months and still symptomatic, they should probably be hanging out with a GI just to make sure that we've done our due diligence. And our job is not to tell patients what to do. It's to tell them exactly what's going on, give them the information, and then help them to make the right decision with the correct information. So yeah, that's our duty, really.
Thank you. Then I have Muhammad asking, can we have GERD even with the esophageal manometry test showing that the esophagus and the lower esophageal sphincter are working normally? I also did impedance pH monitoring and it showed abnormal acid reflux.
Hey, Mohammed. Yeah, absolutely. So, you don't need to have a hiatal hernia or, a low pressure in your lower esophageal sphincter. If you've had the correct investigations that show pathological acid reflux that falls above the parameters that we've set, then you fall into the category for a discussion about lifestyle, medication, and hopefully never procedural intervention.
Excellent. Also a great one from Haley. What do your TIF patients say to you in post-surgery follow-up?
Thanks, Haley. So that's sort of 20 to 30 minutes, not very much because they're still recovering from the anesthetic. But on the whole, the recovery from this is so quick. So most of them are back at home, back at the offices within 3 or 4 days. And I suppose the one thing that the positive feedback is, gosh, that was actually really easy. I was so anxious. I thought it was going to be a big operation. And I suppose the negative thing is for the first day, it is a bit sore. And we put you on a little bit of what I call baby food for the first 7 days. Everything's a little bit thin and pureed just to protect the esophagus. So I get a lot of kickback from them saying, how dare you? But At about 3 months, that's all forgotten and we're friends. And on the whole, the majority of my patients that I've had the pleasure to hang out with have had a good outcome.
Perfect. Can you talk a little bit about, we didn't get into that yet, but talk a little bit about what post-op looks like. One of the big questions we get from patients is, what kinds of foods do I need to eat? They always hear about the diet and they're always worried about that. So can you talk a little bit about what you prescribe to your patients after they have the TIF procedure as far as diet, and then also exercise, and how quickly can they go back to work after the procedure?
Yeah, Andrew, I think that's a really important question. We spend so much time talking about what happens before the procedure and about what happens in the procedure. We sometimes don't focus on what happens outside the procedure. And I have to say that I've learned as I've gone along. When I started off, I was very cautious because some of the guidance that I borrowed from my US colleagues, it's pretty harsh, actually. The amount of time that patients have to be on, a sort of thin pureed diet. And I think the one thing I learned from having done it is how minimally invasive it was in terms of also the recovery period. By a week, most folks were fine. So I've tailored that on a patient approach. But in essence, for the first sort of 2 weeks, folks, you're going to be on, thin stuff, broth, soup, nothing with solids, and then you're going to titrate that up. And what I say to them is be sensible. Your body will tell you when you're ready. But honest with you, I don't follow a lot of the very stringent diet plans. Most of my folks within 12 months are back to eating pretty normally.
Nice. And then what about getting back to, their day-to-day? And then from there, a lot of patients are pretty active. And I think some of the reasons why they have a hernia, they need to get their, what am I trying to say? Get the TIF is because they have that large hiatal hernia. They're like weightlifters or they're very active. So they always ask, what can I do after I have the procedure? So maybe talk about depending on what they do for work, they can go back and sit at a desk, no problem, but you probably would steer away from them going back to the weight room or something like that right away. Yeah, listen, I think the caveat to that is also sometimes the advice you give to patients, they tend not to follow it to the letter of the law, but anything that's going to sort of increase your intra-abdominal pressure, so squats, heavy weights, that sort of stuff. But I did a TIF last Tuesday on a guy in London before I flew out here, and he was running on Friday morning, and he sent me an email over the weekend saying that he's okay, other than the fact that he's very hungry. So most people are able to. Wonderful. That's fantastic. I think we have a couple more questions that are popping in from Facebook. So
we just had one from Din asking, are you able to vomit after having the TIF?
Yeah, so there's one of the things I sometimes do is I go on the sort of chat rooms and blogs just to hear what patients are talking about and understand some of their anxieties. And you're absolutely right in highlighting that is after the surgical procedure, the ability to regurgitate and vomit is lost, which it seems sort of counterintuitive. Vomiting is a reflex, that your body's trying to expel something that shouldn't be there. And it doesn't sit easy with me. Not the ability not to be sick. It sounds a little bit sort of unusual. Not with TIF. Remember, with TIF, even with the best will in the world, we go all the way around because we're upside down on your endoscope. At best, we'll probably do a wrap that will be 270 at the best, 290 degrees if you're really, really good. So you'll be able to burp and.
Perfect. So thank you very much. The only other one that I'm seeing right now was Lynn asking about lifestyle limitations after the TIF, in addition to the the heavier, more active, folks who will weight lift, et cetera. Just are there any normal day-to-day activities that you recommend easing back into, or are you free flowed off those?
Yeah, no, listen, it's an important question. I think people mustn't, in the short term, is small meals more often, but also people mustn't fall into old habits. I do a lot of bariatric endoscopy, and when you do a weight loss procedure, it's a part of the overall sort of a protocol, so to speak, that patients need to engage with and embark on to get the optimum output from that procedure. TIF is only part of that process, and eating sensibly, exercising, moderating weight, all of those risk factors that we've talked about, moderating those, they're part of that package. So I suppose in a long-winded.
Fantastic. Any other questions, Wendy?
Not at this point.
All right. Well, we're wrapping up, getting close to the end of our program today. Before we end, though, Rehan, we just kind of want to give you the opportunity to let the people that are watching, know what is the number one advice that you would give to patients. I don't know if you know or not, but here in the U.S. Next month, which is coming up soon, a couple days, November. We have GERD Awareness Week, which happens to fall the week of Thanksgiving week. And obviously Thanksgiving is a time for us to get gluttonous to some point, if you will, eating. I mean, it's a big gathering, right, to eat a lot of food and then watch football. So it's ironic that GERD Awareness Week is that week, but we are trying to raise more awareness during this time. And to your point, live a healthier lifestyle to help you with your GERD symptoms. So do you have any words of advice for, even a patient like me that I'm still on PPIs, debating if I should get off of them, go see endoscopist? What would your advice be to people out there that may be suffering from?
Yeah, I think it's always nice to sort of circle back to the patient here, isn't it? Because we ultimately, the bottom line is it's a common condition and most of you are fine. You're not going to come to any harm. I think that's the take-home message is don't come off this and start freaking out that, that there's lots of badness going on in your esophagus. That's not the case. I think there's 2 points I want to make. One is a more of a sort of societal thing about, that we're all very blessed to have the opportunities that we have now. And with that comes opportunity and changes in behavior that are causing a bit of a rise in eating behaviors and obesity, and that the implications for that are not just around reflux, vascular health, around mental health and physical health, and that's something that we need to all be cognizant of and embed into the younger generations. The second point is that have a really low threshold for getting in the face of your doc. If you've got reflux symptoms, go and get heard, because I've had a couple of endoscopies. We need to change the stigma around being investigated, and we need to give patients every opportunity to exhibit their pathology to us so we can help them, because we can now. And so it's just that, if you've got symptoms, something doesn't feel right, it's been happening for a while, you've been popping pills, get in the face of your doctor and say you watch this podcast and, there was the irritating guy from London who said I should come and see you.
No, we like the accent. So, it's different over here in the US. So it's nice to have a new accent on our TIF Talk. So, but again, if you are watching from the UK or London area, Dr. Rehan Haidry is there. You can find him at the Cleveland Clinic London. They do have a website, so you can search his information there. He also has his own website. It's www.rjmedical.com. So if you're in that area, you do have help, and there is a trained physician that can do TIF. If you are not from that area and you just kind of want to find a TIF trained physician in your area, you can go to gerdhelp.com. We do have a physician locator on there, and you have the ability to put in your zip code and or search by state, and you'll be able to find the physicians that are near you that are TIF trained. So before we end, I just want to thank everybody again for joining us tonight or today, depending on where you're tuning in from. Wendy, thank you for helping us with the questions.
Thanks for having me. My pleasure.
We appreciate it. And Rehan Haidry, Dr. Rehan Haidry, thank you so much for joining us this evening. We really appreciate you taking the time to educate the people out there in the UK and London and also here in the US, and giving us your perspective on everything. So thank you again for joining us. We really appreciate it. And
Not
for
at all.
those
Pleasure's all mine. Thank you so much for having me.
Thank you. And we're just going to have you hang on for 1 second after we conclude. But to all of you watching, thank you so much for joining us. You can catch us every Tuesdays in around 5 o'clock US time, Central Time. We do have TIF Talks every Tuesday. So again, thank you for joining us. Have a great day and a great evening, and we'll catch you next time. Thank you very much.